You've asked me about a lady who we've had frequent difficulty with communication with the ward following an admission, sometimes for chest infection or urine infection, and they want her to come home. They're ready to discharge her. But she has 4 injections of insulin every day. She has had for about 8-9 years. Her family, who are very, very caring, have a rota, have somebody always looking after her, have provided her injections for her. And they have done it very well. The district nurse service is a support. We visit every 3 months, sometimes monthly, to review and make sure things are okay. And they also have our contacts in case they need to ring us. But the ward ring on discharge and say, can you accept a referral for 4 injections of insulin every day? So the district nursing service currently cannot support 4 injections a day at home. And initially, the response they would get is, no, we cannot accept this referral. You need to review the medication and perhaps reduce the injections. However, anybody who knows this lady would know that this lady's family is able to take this on and have done for a long time. So sometimes they get a response that you should speak to the family. They're able to do this. The ward will then ring again and say, no, we cannot discharge this lady unless we know that you're taking on the injections. Now, that could cause 1 or 2 days delay in discharge purely because the person who is receiving the referral, if it's a senior person like me, I'll say yes, send her home, and immediately ask the family to carry on doing what they've always done. If it's a junior nurse, she would feel that she would have to then arrange for 4 injections a day at home, which is not something that we ever do at the moment. So I think the main problem is when you're on a ward discharging somebody, you have a checklist. You want to tick all these off. That checklist somehow doesn't allow you to accept the family to take this on a complex lady who needs injections, who has renal failure, who has quite a hefty care package. And maybe the confidence in the ward nurse is the lacking thing, to trust your judgment, to take a good history, to find out what was happening before you came in. This isn't new. You came in for a different problem. Why does the plan need to change? Why does the district nurse needs? We are supposed to empower people as nurses. This isn't empowering. In fact, it's very disempowering. The family feel they're not recognized or their input isn't valued. They want to look after their mother, and they have done a fantastic job. She is just going to have the odd admission.
Do you think that older people are being admitted to hospital with conditions that they could actually be treated at home?
Unfortunately, yes, that is still happening. There are situations where older people are admitted to hospital with a condition that could be managed at home. Very often, it's making that assessment as a clinician, as a doctor or a nurse or a paramedic, that this person could be managed at home or this person needs to go into hospital. Now, supporting that decision, which is, in my view, an advanced decision, you need to make an advanced assessment of this person. But how can you do that in a rush, with no background information, with sometimes a patient who's got confusion, frail, elderly? The hospital feels like the safe place to take somebody. Unfortunately, sometimes it's not the safest place for that person. And a course of antibiotics with additional support would be better. Communication around admission into hospital is a big challenge, and I feel that one thing that would help would be access to information about this is the normal circumstance for this person. They're always breathless, and you're never going to get on top of that breathlessness. So don't admit them for breathlessness, or their saturation levels are always going to be low. If they walk to the door and sit down, their SATs will go down to 90, and that's normal for them. Give them a few minutes and they'll be back up to 96. That is critical information that the paramedic doesn't have. But why doesn't that paramedic have it? We need to change the culture around managing information, make it more accessible to family. They're the people who are good carers. We might make all these measures to make it available to the ambulance service, to the A&E, but actually, the people who really need to know that, and they can tell you straight away if they know that it's important, is the patient and the family.